This is a case of a 13-year-old patient with hemidysplastic lipomatosis, and she developed neck and right arm irradiate pain for 2 months, and then she started to develop a progressive paraparesis. And she had a sensitive thoracic dorsal level for 3 weeks prior to the presentation, and dorsal levels were D4 to D6. So she came to Sick Kids, and we performed those images. And what do you think it is? Yeah, we reviewed this case. There was a question of if it would be a hemangiopericytoma or a tumor, and we reviewed with Manu and Prakash, and we felt that it probably maybe could be a fistula because we saw that there was in fact an enlargement of the epidural venous plexus in a venous pouch and compressing the spinal cord. And we did an angiogram, and this is what we saw. So yeah, so a paracordal fistula. And my other question at what it would be. So for the sake of time, it would be for us to reply. But this is a venous. This venous structure represents, in fact, the epidural vein. An epidural venous pouch, in fact, inside the canal, and you have this lesion here around the nerves, the tissue, and a little bit of the vertebral bodies at the exit of the epidural venous plexus outside the canal, right there. So, what are the options? What should we do? I think I've seen a lot of approaches, and everywhere people like to go to these venous pouches and put coils and put stuff inside, but we have to think that this is inside the canal. And our approach is always being to prevent going into the canal and even into the foramen, because then we can make these lesions worse. But and what did you do? And what did you do when it thrombosed? And did you use steroids after? Heparin and steroids, yeah. And it did go. Okay. Okay. Okay, Carol.
Yeah, so we've had quite a few of these cases, these paravertebral arteriovenous malformation or shunts or whatever. And in my days, when I'm not used to using the famous material called onyx, we tried always with our transarterial glue, and I must say we were almost never successful. We have, I think, 5 or 6 cases like this. And eventually the only way we could be successful was the retrograde transvenous approach and putting coils there that eventually made the patients asymptomatic and relieved the pressure. But it will be, I have not seen this case for a few years, so I bet you that you used onyx.
Yeah,
Am I correct?
You were right. No, in fact, I have, a lot of paracord or paraepidural. I think everybody hates it, and I end up, I mean, I have to do all these cases, and I've seen a lot. I try to do staged embols to prevent thrombosis, acute thrombosis of the venous sac, but when it happens, the patient got worse, but with a long-term steroid, at least in our experience, we've seen that clinically the patients improve. So for this case, also, it was anatomically very challenged to go and inject glue. So sometimes when you are injecting glue, when you see you have already a large glue cast into the vein, and this is why I prefer to inject onyx for this case, because also I could control better. We had the brachial plexus over there. We were very close to the vert, and as you see, the lesion is massive. So after some pedicles, I was afraid to be completely lost, and this is why I used onyx, so I could control better. Although I like, So that was my target, and I started. I could find the big fistulous points, but I came from the other side, aiming to reduce the flow first and achieve a regression of the venous pouch, and then in a later session come more aggressively with a smaller venous pouch. So this is what we did on the first session. On a second session, we started attacking some of the fistulas, and we saw that progressively, as you can see here, the venous pouch was smaller and smaller. And on a third session, with more than 50 vials of onyx at the end. I'm sorry, Manu, for that. I couldn't completely cure the lesion, but we diverted. At the end, we were kind of aiming and looking to the reflux to disconnect the shunt to the epidural plexus, and this is the follow-up. So we can still see some onyx, but you can see the canal is open, although there's still some scar of the epidural veins. And we still see a residue shunt, but they are draining out to the thoracic veins, and as you can see here. And the patient became, regressed completely the symptoms, and we are still following her, and she, with MRIs, and she time to time present with brachial plexus pain. And we don't have any plans to go and finish this lesion unless she starts to having more epidural shunts again.
No, congratulations. This is probably very similar to the maxillofacial arteriovenous malformations, the very large ones that are very difficult, much more difficult to manage than the brain AVM. I mean, this is really tough to kill this thing, and maybe not needed either, but because of the collapsal flow from the opposite side, and if you're proximal, it's going to come back, and it's going to come back again and again. So I think you did a great job, and this is probably an advantage of onyx being able to penetrate deeper into the thing than with glue, where we usually were too proximal.
Yeah, for this case, I felt that was an advantage.
That with some fractionated radiation or something like that?
This is something to discuss. Here in Toronto, we have the radiotherapy group, Ronnie, Dr. Schwartz. We have a good a series. Ronnie, we just published it on radiosurgery for fistulas, and occlusion rates is kind of 50%, and the cases that were occluded, they had a very low flow. Here, the flow is still quite high. I'm not so sure if a radiation will be able to get it, but this is an option we discussed on our rounds, and one of our neurosurgeons considered. But at the end, since she's asymptomatic now, we will just watch and see.
Plus the amount of onyx you have there is probably gonna shield the fistula from the radiation completely.
This is a legend. Okay, so those just from those lesions are in fact on the paravertebral and epidural space. They are part of those paravertebral lesions, and they are different from the other lesions. I just put some other pictures of medullary, perimedullary, and dural shunts to show that this is a completely different disease, and the natural history depends a lot on how the vein is, how is the venous drainage. So those lesions, they are spontaneous like this one, but there are a lot of traumatic lesions, and probably the most famous ones are the vertebral arteriovenous fistulas related to neurofibromatosis. And they cause symptoms when there are changes on the venous drainage, and it depends on which systems they are draining. And most of the symptoms are caused by the influence or the reflux of the venous drainage into the epidural plexus. And sometimes it happens many years after the beginning or the diagnosis of the fistula, particularly when some of the venous outputs were occluded. And it's very rare to see a medullary or pyoreflux in those events. They are probably secondary transformations of the initial epidural reflux or the normal drainage of those fistulas. This is a list on the book that Carol said that we all have to buy. I bought it many years ago. I will buy a new one, yeah. So this is probably the best literature to evaluate those paracord or paraspinal lesions. And they have probably the series that we all learned about it. And most patients present with radicular pain, as this patient. And the epidural mass effect in 16%, a venous hypertension in 16%, hemorrhage in 8%, and when the child is very young, some cardiac lesions can be also associated with it. So those are very rare lesions, and the symptoms are related to the venous drainage. Cord compressions are related to the epidural mass, and I think that I've seen some cases in some complication meetings of colleagues putting coils and stuff inside this epidural venous mass. As you've seen on the control angiograms, if we don't touch, they will all regress once they thrombose. I would favor a transarterial approach that can be staged to reduce the flow, observe a decrease in size of the venous pouch, and then a complete obliteration if it's possible. My second case will be a faster one. Is an 80-year-old patient with pulmonary hypertension that was transferred to St. Kitts for potential lung transplantation. She had a progressive respiratory failure here and a right ventricular dysfunction, and she was submitted to an extrapulmonary lung support with a Novalung device. It's kind of an artificial heart for these patients with right ventricular dysfunction. So she was in the hospital. 2 weeks later, she presented with an acute aphasia and a right facial palsy and right arm weakness with an PED NIH assess of 10 when she was accessed on the bedside. So the neurology was fast, and the radiology team over there prescribed a CT and a CTA. We reviewed with Manu and Prakash, and we saw this this suboccluded left MCA. So this is the list of options that we heard on what to do for this patient. So she was already on the heparin. Some people would like to increase the heparin, reverse and inject TPA. So we kind of went over all those questions, and we convinced everybody to agree to perform a mechanical thrombectomy. So our approach at Sick Kids involves we use a 5 French approach, and we understand that the differences on these procedures in kids, and we use a 5 French distal access catheter, either to perform a direct aspiration or a stent retriever 3 millimeters to do a Solumbra technique. So this is what we did. So you can see here on the angiogram, on the left ICA, the clot is crossing here the MCA and seated in this M2 branch. After one pass, we had this result. 4 hours later, the patient had decreased and reversed the symptoms. So this is the CT on follow-up. 4 days later, the patient, after the first thrombectomy, became again symptomatic. They had fixed the level of the INR of the patient and changed the heparin protocol. But despite of that, she had a new episode of aphasia, right side hemiparesis, and NIH at this time of 12. And this is the CT with a clot over there. So now that comes the question, what would you do? I can tell you it was hard to do the first one and to convince everybody. And now? Huh? To go there. That's it. So we went over all the discussions on recurrency and 4 days and all the different approaches. But I think we were all on agreement that we should go back again and do another mechanical thrombectomy. We've seen patients, in adult patients with AFib, sometimes they have a second stroke inside the hospital, and I think all of us now on the adult world, we have cases that we did 2 thrombectomies in a short period of time. And this was the second angiogram, a partially occlusive clot. This is the result after the mechanical thrombectomy. The patient had, we finally saw that was clot on the tubing, and they removed the tubing. But then on the weekend, on the following night, she had a lung, and she got transplanted, and was a success story that we had on our stroke program. I think my time is over. Thanks for your attention.